About the situation in Wales, we have a long history of drug use. We really like our drugs in Wales, as well as our alcohol. We have a substantial injecting population as well. But over the last few years, much as everywhere else, we have seen a change in the drugs market. I've worked in drug services and frontline and in research for 25 years. And I have to say the last 8 or so, 10 years has been a real revelation, because I've had to learn a lot of new things. Changes in terms of the way people are using their drugs, taking their drugs, but also in the drugs available. We have been hit quite hard with new psychoactive substances and injecting of new psychoactive substances amongst our historic opioid using population. We also have extensive use of steroid and image enhancing drugs, and that's just growing. So I actually lived in Ireland, in Bantry. It was a beautiful place, for a number of years, and so have some sense of the picture in Ireland, but I know it's been a very movable feast and is continuing to change. So I think we have some comparators there.
That's great. And what evidence do you have for the effectiveness of this strategy, in particular drug testing in the Witness Project?
Well, one of the things, as I said when I started, we really didn't have a role. So my first part was to look at what evidence we had on the nature, scale and harms associated with drug use and drug and alcohol use. I've heard polydrug use, the term used, and it's very much representative of the patterns of drug use that we see in Wales. We started off by undertaking and continue to undertake an annual prevalence estimate of problematic drug use, so that we're able to quantify the population by demographics, but also by drug type and changing drug type. And I think that's been really key, because when I started, I think they based the resources available for substance misuse on the number of people in treatment. Completely erroneous, a very small subset, I think it's fair to say. So that kind of research and prevalence estimation is key. In addition, we have developed the Harm Reduction Database, which is a national data collection system right across Wales. It's covering off all of our needle exchanges, so 257 needle exchanges, all of our treatment services, naloxone services. So we have a much better picture of individuals who are accessing our services, but only, for example, needle exchange, no other treatment services, so that we can really target investment where and when it's needed. I touched on the steroid and image enhancing drugs. We've developed a website and a survey, and we've just completed the first of its kind, actually, 700 face-to-face interviews with steroid and image enhancing drug users in terms of both the harms that they've experienced, the nature of their use, but also contact with health services, which is minimal. So we can really explore. We know now that there is evidence of bloodborne virus infection and poor injecting practice amongst this population, but absolutely no contact with treatment service. And finally, the Wedinos project, which is a service that tests, enables any individual across Wales to submit a sample of drugs, new psychoactives predominantly, but often combinations of drugs and very often unknown. And we've been running this project since 2013. It's funded by Welsh Government. And as I said, any individual is able to submit anonymously a sample. We ask age, gender, and whereabouts, area of residence, so that we can map trends in availability of drug use, the types of drugs that are available, but also the harms associated with use and who's using. I've heard a lot today about young people, but actually our new psychoactive population runs to, I think our oldest person who's submitting is around 68. And the greatest growth in our contact with treatment services and hospitals is in an older population. And without the evidence, you cannot tailor services to meet these needs. So it's the whole age range that we're seeing. So any individual is able to submit a sample, and in addition we receive samples from amnesty bins in our nightclubs, for example, and we're able to test any sample for non-evidentiary. This is a health intervention. We provide the testing in our laboratory, and we publish all the findings on the website so that individuals can be better informed. So we publish what people thought they had bought, what it actually contained, the legal status of the contents of that drug, and also the harms that individuals who have used, and the best evidence from our National Poisons Information Service have been able to find in relation to these drugs.
Great. You know, we spoke yesterday and you told me that in the 2.5 years that this project has been set up, you've received over 4,000 samples. Can you please tell me maybe, you know, is this really a solution to get like hard to reach people? Is you know, people that might not normally come forward and, you know, maybe might not respond to education? Can you explain maybe the awareness, you know, and the importance and effectiveness in reaching hard to reach populations?
I think the project is innovative in that it is, I believe, the only one that actually recognises the importance of communicating with people who are using drugs. Very often projects, and I've worked in health for a long time, we're very good at informing other health professionals or academics and writing papers. We're very, very poor at recognising that actually people are making choices out there. So I think this project, as well as the other projects, the steroid project, for example, but also the data systems, allow us to identify those people who are in effect hidden from our services, maybe even also from criminal justice, which is a good thing. And it provides a mechanism where people feel more confident about being open about their drug use and engaging in a respectful communication so that they can reduce their own harm. And I think that's absolutely vital.